So morning again, I'm Sue, and as I said this morning we're just going to go through a bit on eye assessment. I'm sure you've gone through this already now that you nearly completed your course, but we'll just recap and just see what your knowledge base is like and go through a few things. So we're going to break it up into two sections, going to do a bit on eye assessment and then a bit on eye management, which is primarily medical work, but as a nurse you obviously have to know what the doctor is going to do as far as eye management is concerned. So are you both in ED at the moment? So have you been involved with triage at all?
No.
You haven't seen them or watched them operating out in the triage room. So do you know what triaging is? You should know from doing the paramedic stuff.
Mm-hmm.
Yeah. So just with categorising eyes as doing part of your initial assessment when a patient arrives, we categorise them either as urgent or semi-urgent depending on what the patient's eye injury is. So if it's something that's involving the anterior chamber, like they've got a piece of dust in their eye, or they think something's rubbing in their eye, then that's fine. It's uncomfortable, but they can sit and wait for an hour or so. But if they've got a penetrating injury or a chemical burn or anything like that, then obviously that's more urgent.
Mm-hmm.
As far as the chemicals go, we mark the alkaline burns even more urgent than the acidic burns, because alkaline burns really damage eyes. So those are people that are usually cleaning their pools on the weekend, that don't wear protective glasses when they're either putting the acid into the pool or they then going to put the buffer in, which is the sodium bicarbonate, which is an alkaline. And then if the wind's just blowing just a fraction, then that can blow into the eyes, and it's extremely painful, and it can burn and do a lot of damage to the eye. And then obviously penetrating injuries, and also blunt force trauma injuries. So those are normally either people that are playing sport, that have got an elbow into their eye, like a rugby scrum or something, where they've really gone and got a good elbow into their eye. Or the other, what we see is in MVAs, when there are the airbags being deployed, that often pushes up, and their face often gets hit with the steering wheel. As they go like that, the steering wheel often just catches them. So just make sure then that you've got a good history from the patient on arrival, because the triaging on how urgent the care is obviously important. Then as far as the assessment goes, we are looking at the symptoms that they say they've got. So what symptoms would a patient, if I've come with, say, a piece of metal filing in my eye, I've been doing some grinding or welding, and now I come in with a piece of metal, what are you going to ask me? What symptoms do I have?
Pain.
Yeah, what type of pain? You're going to say,
Yeah.
Is it
a sharp pain?
Yeah.
Is it burning pain?
Yeah.
Is it a dull pain?
Yep.
Is there pain at all?
Yep.
Or has the nerve been?
Okay. So we need to make sure that we ask them what type of pain that they've got, because it can be very broad. And some are just discomfort, and obviously others are really in excruciating pain. Those that are, we have to continue with the other nursing management with them in terms of pain relief and so on, while we're assessing the eye, because we are dealing with the patient as a whole and not just the eye. Just going back to triage, just as a matter of interest, when we are doing triage, we triage in life, obviously, so are they breathing and do they have a pulse, but it goes patient's life, limb and eye. So, someone who's had an traumatic amputation of a limb or, sharp bite, something like that, then they obviously can sanguinate. But the eyes fit into that same category. So it's really important that we get onto treatment really quickly. And we can only do that once we've assessed the patient. So as the nurse, you've now got the patient and the triage nurse has taken them and said, they've got something. They think something flew into their eye when they were out jogging this morning and it's really irritating them. And it's more just a scratchy feel. What are you going to look at in terms of their eye when you've now got them seated in the ENT room, and that's where you are this morning, you're out the back there. So I've come in as the patient. What are you going to ask me?
Colour.
Yeah.
What are we going to ask the patient?
Yeah, and what are you going to look at with the eye?
When did it happen?
Yeah.
Has it gotten better or worse?
Yeah.
You're going to be looking for irritation, so redness.
Yeah.
Is there any swelling around the eye?
Yeah.
If it's an insect.
Good. Yep.
Is it reacting still?
Yep.
Are they equal?
Excellent. So that's our job. We can help the doctors by doing that, and when they come around then to do the assessment, you can say, look, they complain, it's really, that eye's really red, or, I can't actually see anything. But I've asked them and they still complain. So it's good for us to do our own assessment, and obviously then your documentation that goes with it. Have you enjoyed doing the documentation electronically?
Yeah.
It's quicker. It's a lot quicker.
It is, isn't it? And you can't really forget. It sort of prompts you to put in data as well, which is really nice. And then we also need to just address the patient's history, because I've been out jogging now and I've got something in my eye. And then what about my patient history? What are you going to ask me?
If they have any comorbidities or conditions, so they might be diabetic.
Yeah.
They might have diabetic retinopathy.
Yeah.
They might have conditions like glaucoma or
Yeah.
cataracts, or have recent laser surgery.
Perfect. So that's what we need to know. We need to know what their comorbidities are, but also if they've had any recent surgery to their eye or on current treatment for any eye conditions, because the doc comes and wants to put in drops and so on, that can be counterproductive. So we just need to ask those questions as well. So then we're getting on to more the examination side of it. So have you done visual acuities while you've been in the WEC?
No.
You haven't done patients' VAs when they come in? No.
I don't think so.
Okay. Good. So that's what a Snellen chart looks like, which you'll see is the chart that's up on the wall in the ENT room, where the patient then sits on the opposite side. And so this was designed by Snellen. He was an ophthalmologist in the 1800s, a Dutch chap. So this has obviously been brought to size so that you can actually test somebody's eye in a room. But what it means is that a person, you can test their visual acuity, which is only basically their central vision. It's not looking at the peripheries at all, but to give you a broad sort of guideline whether they're seeing okay or not. So you do need to make sure that they have their glasses with them, or that you can't do this test if they haven't got their glasses with them, or contact lenses, or anything where they would have normal corrective manner of some kind for their eyes. But say the patient can normally see fine, and now you want to test and see this affected eye, how they're seeing. This is the Snellen test that you use. So in our ENT room, because the room's small, this is designed to be read at 6 meters. That on the side is written in feet. So actually if you put, that is 660 up there, 6/60, and then going down the line, 630, 621, 615, 612, 69. This is because we work in meters. 7.5/7.5 and 6.6. So the 20/20 that you hear people saying they've got 20/20 vision, they're talking in feet, which is 20 feet. So you should really test it with 6 meters, but as you know, our ENT room is really small.
Yeah.
So what we've done is we've put the chart up on the wall backwards, back to front, and then the patient actually looks in a mirror and then reading it back. So we're making the 6 meters out of the 3 meters.
Right.
Yeah.
Someone's changed that.
Is it not there?
It's reading the right
way around?
Yeah.
Is it?
Yeah.
Okay.
That's interesting.
Oh, there is a little switch on the side, so maybe they just got someone to sit and read it.
Yeah.
But if you turn it, because you know it's in that box, you can
okay.
flip it around.
No,
Then if
I didn't know that.
No.
Yeah.
So then if they're sitting in that chair opposite, that would give you your 6 meters. Otherwise it's not long enough.
Yeah.
Otherwise you must get a smaller chart to make it so that it's still dimensionally correct. So what you do then is to test the person's eye. We get them to test their bad eye first, and we do that so that they don't memorize the letters, because if I did your good eye first, it's such a short space of time between doing the one and the other, that then you'd say, oh, I saw that, and then you could actually, even though you can't see it that clearly, or the patient can't see it that clearly, start reading out letters that they can't actually see. So we test the affected eye first, and then test the other eye. So you ask the patient to cover the eye that you're not testing, obviously, or you can use a shield, or you can use, you'll see there's one of those like little, almost looks like those little mask things that you hold, just to cover their one eye, so that they're only looking with the affected eye, and then ask them to read from the top, obviously starting up at the E, and reading down until they either say that they can't see it, or that you see that they're making quite a few mistakes. If they only make one, then we let them carry on with the next line, because say like a C could be an O, like that C could really, they might see it as an O, but if they're starting, and they can't, and they say that's an H or something, and an X all of a sudden becomes an H, then that's like a real error. Then you take the line above where they've made the mistakes as the line that they can read. So that means then, let's say the patient can read that line 5, PECFD, with their eye that's been affected, then that means that what a normal person can see from 12 meters away, a signboard out on Corro Drive from 12 meters away saying, bus stop ahead, they need to be at 6 meters before they can read it. So that's where the 20/20 or the 6/6 comes in. So 6 meters means what the average person can see at 6 meters, I as the patient can also see at 6 meters. Then your vision's good. But if someone comes in and they go, oh, I can't really see out of that eye, and they only get to line 2 and can read the F and the P and then nowhere else, then that means what you can see from 30 meters away, I have to go right up to 6 meters before I can see it. So that's what visual acuity means. And then when you go back, if you look in the documentation, if you go into any patient, and you go into your tick boxes under eyes for visual acuity, you'll see it will say /6/6. So you put the number that the patient gets over the 6 meters, which is the, So that's how visual acuity works. Not many people who haven't done it before really understand how it works. They all know about the 20/20, or say, 20/20 vision. But it does give you a good indicator of if a person has a major problem, or if it's just something that's irritating their eye and they can actually see properly still. So that's visual acuity. Did you have any questions about that?
What happens with dyslexic patients?
Oh, so there's a whole lot of different charts. This is just the chart that's called the Snellen chart because that was the one that the chap devised. But there's pictures, there's, I don't know if you've seen the one with the E's where they're just all facing different ways. So you'll see it upside down and then left and right and so on. So they can just say which way it's pointing. So they're not actually reading the letter, they're just reading which side the open ends of the E are facing. Because you can do visual acuity on children too, and so then you can use, you know, a picture of a teddy or something, but then it gets smaller and smaller and smaller, the different types of animals that they use, or they use pieces of fruit on there, you know, put a big banana up the top and then an orange and then an apple and so on, but they're getting smaller and smaller every time until they say they can't see what it is.
Yeah.
So there's about 50 different charts out there that a person can use.
Okay.
This is just the standard one that's in all EDs and usually behind a doctor's GP room door. But if you don't have enough space, then you need to make an adjustment so that it's still accurate. So does that answer that? So I used to quite enjoy doing this. Quite interesting to see what people answer. You can actually just get them to blink in between too, because people when they're trying to stare like that, their eyes get a bit dry, and then they say, oh, they can't see and it's gone a bit blurry. But they just need to blink and just, you know, get some fur back in their eye, and then just make sure that you document that. So then obviously the doctor can use the ophthalmoscope as well to have a look at the eye, so can you for that matter. And what else can we test? Say I've been cleaning the pool now and I say, oh, I've got something in my eye, I don't know if it was the acid or if it was the chlorine. How are you going to know if that's an acid burn or an alkaline burn that I've got in my eye?
Depends. Did the burn happen to yourself or to someone else?
No, I've come in now, I kind of go, oh, I was sorting out the pool, and I don't know if it was when I was doing the acid or if when, first of all, I shouldn't be putting the chlorine in at the same time, but let's just say I was working with both, and I was getting them ready, and I don't know, something's gone in my eye, but I don't know what it is.
Okay.
Can you irrigate it or something?
Yeah, but before we will irrigate it, you're quite right, but that's in the treatment part. As part of your we're still on examination doing your assessment.
Is there something like, you know, like the Littman paper?
Yeah,
Is it something
absolutely.
similar to that?
Yeah, just like that. That's what you use. So you just take off a little piece, and you just pull the person's eye down, and I'll show you there. You pull it down like so. And then just into like the fold in there, you just hold the piece of paper there just for a second, just to let it take up some fluid, and then it will change colour.
Yeah.
So you can get special ones for the eyes instead of, you know, going down to the utility room to go and get litmus paper. But I mean, it's in the treatment room, the same for the nasogastrics and so on. So it's the same paper, but you can get them in fancy little containers where you can just pull out a little strip and leave it in the ENT room. And so then you just press it down into the eye like that, and you get a little bit of fluid, and then you'll see whether it's an acid or alkaline burn. So that's a good tip to know. The doctor can obviously put some fluorescein into it, which is this picture here, which I just fall off. So the fluorescein is yellow. I don't know if you've seen them using the yellow fluorescein dye.
It's on the top of the fridge.
Yeah. So it comes in a what they call a minim, in a little minim. It's like a tiny little vial, and it's yellow, and so it stains the eye. And then they look through the slit lamp, which we'll go through in a sec, which has got blue light. Then they use the blue light, and so blue and yellow turns green. So when they're looking through the blue light, if the person has got an abrasion on their eye, like a corneal abrasion from that thing that's been flying around in my eye, then the abrasion turns up green because blue and yellow make green.
Hmm.
So if you put the dye in and they look through the blue light and it's just, they can't actually see anything because then the eye's clear, then it's just blue, that's how it's going to show up.
Hmm.
So that person's got a fairly substantial corneal abrasion. Obviously it's blown up, but even if you made that the size of an eye, like dimensionally from a person's eye, that's a pretty substantial corneal abrasion that they've got. So that's how the doctor can go, oh, you've got a corneal abrasion. And you go, geez, they're really clever. They're that clever because they can see that. So then you have that answer, and this is what they're looking through, which is that slit lamp in the ENT room. So it's really just a big magnifying lens, that's all it is. They're only looking at the anterior of the eye with this. They need a diagnostic set to really look into like their retina and into the eye. This is really just showing up, magnifying like this their eye so that they can have a look and see for that minuscule speck that feels like it's a rock in your eye, but it's only like maybe one little grain of sand. They wouldn't be able to see it normally, but then with that being magnified like that, then they can really see it, and to them it comes up this size, and then they can know that how to get it out.
Yeah.
So that's a real good tool, that one. A pretty expensive piece of machinery there. They look after that machine pretty well. So that's as far as your assessment goes. So now you've decided that the patient's got that burn, and as you said, you can irrigate their eye. So how are you going to irrigate it?
Saline.
Yeah, and with what? How are you going to get the saline in there?
Syringe.
Yeah, you could, but you'd have to stand there for a long time then to flush their eye enough.
So like irrigation line or something, but
Yeah. Have you seen them use a Morgan lens?
No.
No? Okay. See, I'm pleased I chose this topic. So it doesn't happen often, so even though you've had your stint in ED, it's not something that you see every day. So this is a Morgan lens. It comes in a packet like so. And it's basically, you can actually feel that. The cup's quite hard, but it's like a contact, well, a very hard contact lens. But the tubing is very soft. Yeah. So what we do is we connect this to a bag of saline.
Also.
Yeah. And otherwise you'd be standing there flushing. You know how they come in and they go, oh, I've been flushing my eye before I got there. The amounts, when you think you've been flushing for a long time, you actually haven't been flushing that much, really. It's a bit like brushing your teeth. You know, you brush your teeth and they say that you must brush your teeth for 2.5 to 3 minutes. There's a lot of people that don't brush their teeth for 2.5 to 3 minutes. You go, and you go, oh, there, brush my. If you timed it, it must probably at best come to a minute. There's very few people that actually stand for 2.5 minutes brushing their teeth. The same with eye irrigation. Is people go, I've flushed it all out, and you go, how long did you do it for? Oh, I don't know, but you know, I used a bit of water, and it's not enough. You really need. Don't worry, I'm not going to put this in your eye. So you just use saline flush. And you just make sure that it's all primed through, and including your lens. If I can get the end off. So this fits the end connection. If I wet this whole bit, the end connection actually fits into the end of your giving set. So you can just prime it. Make sure that you've got fluid through there. And then you need to insert this in the patient's eye. So what you do is you ask them to look down and then you pull up their lid and put in under their top lid while they're looking down, and then you do the opposite. You go look up, and then you stick this into the bottom part. And so then it's like a little suction cap. It's just on the edges there onto their eye, not flat onto their eye, otherwise it wouldn't let any fluid through. That's why it's pretty hard, because if it was too soft it would just mold up against their eye and you wouldn't actually be able to get the fluid through. So it's just sitting like that on their eye, and then you start flushing. So you do need to just put, so if this is your patient here and you've got this now in, we usually just put a piece of tape on the side there just to stop it from pulling, and a kidney dish and a couple of towels, because it does run out of the eye all the time as you're flushing. And then you just turn it on and you just let it run. So in the beginning they sort of say, oh no, that's okay, oh that's fine. But after a while, from having the water running over their eye all the time, it does start getting quite uncomfortable. And so then we usually stop if they feel like it's too much. Otherwise we say, oh, there's just a little bit left, let's just try and flush as much as possible. Sometimes with a bit of luck you can actually see what you've flushed out. It'll flush into the kidney dish. And you go, oh, there you go. There's that tiny little piece of stone that flew into your eye. There it is. And then we can just put in some chloromycetin ointment or something afterwards. So the Morgan lens is what we use the most of, and that's standard emergency treatment. And then obviously you need to put on an eye patch afterwards. But you must be pretty good at those. Yeah? You put them on?
I have.
You have?
I've never
Haven't?
put my patch on.
So when you're putting on an eye patch, let's say the patient's all been done and dusted now and it's got some chloromycetin ointment in, doctor said, oh, can you just put on an eye patch for me, and then they can go. What we do is we use one that we fold in half first, sort of to put into the socket a little bit. Take my glasses off. I used to wear contact lenses when I was young. And then when I needed to see for all different levels, I had to get graduated lenses, so then the contact lenses became a bit complicated. So what you do is you fold one first to put that in, because otherwise if you're putting it over just like that, you've got this whole gap sitting here and the person's still actually blinking away and not really resting their eye. They can even open their eye and look at the pad then. So you put it in half just to fill the gap a bit once the eyelid's closed, and then you put this patch over.
Okay.
So that otherwise you'd have your whole socket, the whole orbit, would be sitting with a big gap on it, because you're sitting with this over the top like that. So you put a half of one in first, and then, so just to give it a bit of support, and then that one's just going over the top, like that. So that's sort of look like an eye patch. When don't we use eye patches?
Protruding or
Yeah?
when stuff's sticking in it.
Yeah? Or for a penetrating injury. So you don't want to go and put that on and add more insult to injury. You've had a look and they go, we get people with nail guns and, the nails from nail guns. And have you seen them in their fingers or anything like that? Yeah. In hands and so on. You'll see, once you're out there, you'll get those sorts of calls. Luckily we don't see it often, but you can have a penetrating injury to the eye. And then that's when you would use a shield as opposed to an eye patch, because you don't want to then push onto the protrusion in any way. So sometimes you can't see really like a lot of the end of it if something's gone into the eye. Maybe, it could be something that long, maybe only, 0.1 of a millimetre sticking out. You still don't want to press it in any further, because now you have to transfer them to, a tertiary hospital for major eye surgery. So then that's when you just use a shield so that it's protected, but that you're not pressing on.
How is that going to stop them from blinking though? Like it doesn't.
No, it's not going to stop them from blinking. It's not going to stop them from blinking. It's just going to stop them from touching their eye and from rubbing their eye, but it's not going to stop them from blinking. You can't. yeah, it's just one or the other. But if you stop them from blinking, they would still be able to, on that, still go like this and go odds, then pushing whatever it is even further in. So then we use the eye shield rather. For children, we often put the eye shield over the eye patch.
Yep.
Just because with this, then they also stop picking on it and so on. And just because they're running around still and can, they knock themselves a lot, put the eye shield on just as a bit of extra protection. And that's that, I think. Obviously with eye drops, works the same as your other medications, that you'd have to ask the patient to go through your 7 rights first before you put any medication into the eye. And we don't use eye drops that often these days, unless they're obviously having surgery where they need to have their drops done before surgery and so on, where they're putting atropine drops in. Just remember to discard the first drop. So you don't know where that end's really been, so we always just discard a drop first before we go and put it in a person's eye. And then obviously follow the instructions, whichever one it is, whether it gets kept in the fridge or whether it can be at room temperature. And that's it really, I think. So, any questions?
No, not really. That was pretty straightforward.
Good.
Yeah.
Excellent. So there, at least you learned something today.
Yeah. Cool.
So now you can go back and do visual acuities, and then you'll be able, and someone says, well, what does it mean when you say I'm 6'12" or I'm 6'15"? Then at least you can explain to them that's how poor their vision is, that they would need to be at 6 meters where the average person can read that same sign from 12 meters away or from 30 meters away.
Yeah.
So it goes obviously right up to 60 meters away. So that's the signboard, down the other end of Cora Drive when you're going home, and it says, I don't know, South-East Expressway or something like that.
Yep.
You're in your car here or on your bicycle or on the train reading a notice. 60 meters away is quite far. This person that has this eye injury would have to go right up to that sign to 6 meters away to read what it is. Then you know that the eye's damage is pretty severe.
Yeah.
So that's why it's good for the nursing staff to do the visual acuity as part of the assessment when the patient arrives, because it gives them a good indication of, even though the patient might say it's really severe, their pain, if they can still see with their eye relatively well, then you know that the injury is not too severe. But someone said, oh May, I can't actually feel anything, I don't really have any pain. And then with their good eye they can see fine, and with their affected eye they can't see anything, then you know that there's something. You could go to the doctor and say, hey look, I think you need to come and see this patient, there's something like really going wrong with their eye, because their VAs are terrible. So that's the nursing part of doing the eye assessment. So there you go.
Cool.
Thank you very much.
Thank you.
Very nice meeting you, and enjoy the end of your training. So just stay there for a sec. I'm just going to go and switch the camera off.